So let's get into the new ESMO data. We had 3 phase 3 PARP inhibitor trials at the European Society of Medical Oncology in Barcelona, Spain. And they were the first 3 presentations in the presidential session, which sort of as in ASCO, it's the plenary. So the first 3 main trials were PARP inhibitors. I'm going to describe to you the one that I was involved in as the last and senior author. It's called PRIMA. PRIMA, also called GOG 3012-3012, was a randomized trial of 487 patients, 2 arms. Took the highest risk patients, newly diagnosed advanced ovarian cancer, but patients that had incomplete debulking or patients that needed neoadjuvant chemotherapy, and randomized them 2-to-1 to receive niraparib, initially at 300 milligrams once daily, and ultimately over time we said let's start our less than 77 kilogram or less than 150 baseline platelet count patients at 200, and randomize them to maintenance, 3 years of maintenance niraparib or placebo. And the primary endpoint of that trial was HRD.
Right.
So again, this is becoming an HRD.
And a hierarchical again, where the step down then was the intent to treat after that. Yeah.
And it met its primary endpoint.
It did.
And simultaneously published in the New England Journal.
Right.
Okay. So again, the point of that was that in the HRD positive group, beyond BRCA, there's an opportunity for PARP maintenance. Because we already had PARP maintenance in the BRCA mutated patients for olaparib, this study called SOLO-1. But we want to do beyond BRCA, okay? So I have a little scorecard here, a little paper that talks about the hazard ratio. So the hazard ratio for the BRCA patients in PRIMA was pretty close to SOLO-1, so that's easy.
0.4 versus 0.3.
Yeah, but there were higher risk patients, and if you look at the higher risk patients in SOLO-1, it was actually 0.37 to 0.44.
Yeah, I mean, I think that's one thing we need to point out from the get-go. We're going to start throwing hazard ratios and confidence intervals around here. But it is important to understand that these are distinctly different trials based on a number of factors. So, the inclusion criteria of who was eligible, the histology differed a little bit between the 3 and SOLO-1. And then you have, obviously, SOLO-1 was just germline with a couple of somatics thrown in. And if we look at the statistical analysis plan, it was somewhat different for all these. The primary endpoint differed between these trials. And the patient population in terms of number of stage 3, stage 4, as you said, it was interesting to be stage 3 here, you had to have residual disease. Right. So as you can see by the control arm, it's a pretty high-risk population.
Yeah. We're sports fanatics. He always says these guys got to work on their technique. I learned a new technique at ESMO. Yeah. The technique is let's take an exploratory endpoint, make a definitive conclusion,
right,
and then cross-trial compare.
On an unplanned analysis.
And then cross-trial compare.
That's perfect.
So that's not a good technique.
No.
That's okay, but that's sort of what we need to be very sensitive about. And the take-home message is that PARPs work in frontline maintenance beyond BRCA. Period.
Yeah,
okay?
I mean, all 3 of these trials hit their primary endpoint,
that.
and we'll get into that. But all 3 of them hit their primary endpoint, which obviously you're probably not going to get to the presidential address unless you hit your primary endpoint.
That's
so they were all
exactly right.
successful trials.
So in PRIMA, if you were HRD positive and you had maintenance treatment, you had an 11-month improvement in progression-free survival from 8.2 to 19.6. And I take the BRCAs out of that, so that's HRD non-BRCA. 11-month improvement in progression-free survival. Do you like that? Will you use niraparib in the HRD positive patient population for maintenance?
Yeah, I mean, I think the data is very compelling. I really do. It's a simple intervention, and I thought it was very impressive data. And don't know how you interpret the HRP, the proficient, but those that were BRCA wild type and did not demonstrate any HRD, I call them HR proficient or homologous recombination proficient.
So HRD negative and HRD proficient are the same. Yep. I'm sorry, but that's
exactly. So just to be clear on that.
They didn't do well. There was less than a 3-month improvement in progression-free survival.
But they hit their hazard ratio, and it didn't cross 1. So at least there's a signal there, because you can look at the mean, And that's just the morphology of the curves. They sort of come together, but you could still have some benefit. Point being that, again, we don't have this completely figured out because there shouldn't be any benefit in that group if we're accurately measuring the homologous recombination. But so there are still some patients that benefit, which gives me real confidence that in those that do have HRD, we're really making a difference. That's my point. It's not that I want you to go out and treat everybody that's HR proficient, because I agree that that median is, it's in the gray area of whether that's going to carry water. But it really builds great confidence towards those that have homologous recombination deficiency.
You know, one of the things that I was struck by is that, I get it was a high-risk population, but if you were HRD negative, the median PFS was 5.4 months. So not only are PARP inhibitors not going to work, but nothing's going to work, because remember, HRD predicts chemotherapy sensitivity. So we used to think that the biology of the tumor was secondary to the size of the knife, that if you just try harder and cut all this out, it's going to make it better. Listen, if you're HRD negative, that is the high unmet medical need now in ovarian cancer. Because even if you have large volume residual disease and you have the right molecular signature biology, you'll respond to chemotherapy and to PARP.
One of the things that I found most interesting with Solo 1, which looked at olaparib for those with mutation, was how poorly the control group did.
Yeah,
right? So these patients had to have a mutation. I think our bias was these patients are highly sensitive to DNA damaging agents. So even if you were in the chemo arm with no PARP inhibition, you're in the control arm there, you would have a longer PFS, and the PFS in that group was 13.8 months.
14,
yeah, 13.8 months. In that group, I think many people thought that the control arm would outperform, and it didn't. It didn't. And if you look at the curves, the drop-off in that first 6 months, which means if they're dropping off then, what happens? They're platinum resistant, and our options are very few. So to be able to extend that and push that further, I think is important, and I think you'll be able to do that with these PARP inhibitors.
So last year at ESMO, Solo 1 taught us that in BRCA mutated patients, big benefit, but if you did nothing, they get poor. Now at this ESMO, beyond BRCA, HRD positive, not quite as big a benefit, but still clinically important, and then HRD negative patients do poorly.